When a patient presents with decompensated heart failure and turbulent flow across their prosthetic heart valve, the clinical starting point is ultrasound. Prosthetic heart valve, or PHV, implantations are increasing globally. As a result, valve dysfunction, whether from physical obstruction, structural deterioration, or localized infection, is now a routine clinical encounter. To establish baseline hemodynamics of a failing valve, medical guidelines mandate both transthoracic and transesophageal echocardiography. These ultrasound techniques excel at measuring pressure gradients and blood velocity, but they face strict physical limits. The primary limit is acoustic shadowing. The metallic stent frames and dense synthetic sewing rings of artificial valves physically block high-frequency sound waves. This creates dark, obscured regions in the ultrasound image, hiding the exact anatomical structures causing the abnormal blood flow. To bypass this physical barrier, clinicians use cardiac computed tomography, or cardiac CT. X-rays penetrate the dense hardware that sound waves cannot. Echocardiography detects a functional effect of a failing valve. Cardiac CT maps the specific physical mechanism driving it. Before a CT scan begins, the physician must identify the exact prosthesis model in the patient. Manufacturer size labels do not reflect the actual internal orifice dimensions of the implant, making visual confirmation essential. These photographs illustrate primary surgical valves, mechanical designs with tilting discs, and stented biological valves from animal tissue. Notice the thick white fabric suture rings. By contrast, transcatheter valves consist of biological tissue inside an expandable metal stent deployed directly into existing native anatomy. The choice of hardware dictates the patient's clinical trajectory. Mechanical valves offer lifetime durability but require permanent anticoagulation therapy. Biological valves avoid strict blood thinners but have a limited lifespan before structural deterioration sets in. Each hardware type also introduces specific imaging challenges. Mechanical valves, particularly older tilting disc models, scatter X-rays intensely. This generates severe beam hardening streaks, dense white lines that degrade the surrounding image quality. Because every valve type possesses a unique artifact profile and a distinct mode of failure, a static one-size-fits-all scan will fail. Clinicians must engineer a highly customized CT acquisition protocol to see the pathology clearly. A conventional, static CT scan is useless for evaluating prosthetic valves. The imaging hardware must capture rapid, four-dimensional kinematics to freeze the motion of the moving leaflets. The mandatory protocol requires an arterial phase acquisition synced perfectly to the electrical rhythm of the heart. This is achieved through either retrospective ECG-gating, which continuously scans the entire cardiac cycle, or a wide-window prospective trigger that activates the X-ray tube only during specific phases. By extracting and reconstructing images at 5 to 10% intervals across the cardiac cycle, radiologists can generate a fluid, dynamic assessment of leaflet motion. To mitigate hardware artifacts, the protocol demands high kilovoltage settings, which increase the energy of the X-ray beam. Alternatively, dual-energy CT scanners can synthesize high kilo-electron-volt monoenergetic reconstructions to suppress metal blooming and clarify the edges of the device. Initial axial, coronal, and sagittal CT planes rarely align with the implanted hardware. Using multiplanar reconstruction, radiologists rotate the axes until perfectly parallel to the prosthetic valve ring. This adapted axial plane views the leaflets precisely on edge, letting clinicians calculate exact opening and closing angles. Establishing this sub-millimeter, motion-free kinematic baseline isolates the mechanical behavior of the valve. It provides the empirical data necessary to differentiate between specific, life-threatening pathologies. Obstruction of a mechanical valve is a highly variable crisis. A patient might be completely asymptomatic, or they could rapidly decompensate into cardiogenic shock as blood flow halts. The critical diagnostic decision hinges on identifying the exact material blocking the valve. If it is a blood clot or thrombus, the patient can often be treated medically with anticoagulants and thrombolytics. If the blockage is Pannus tissue, the patient requires immediate redo surgery. This CT scan demonstrates the spatial signature of Pannus, a thin, circular, hypodense rim directly underneath the mechanical valve ring. This abnormal growth of myofibroblasts and collagen fibers favors the subvalvular space, registering as dense tissue over 145 on the Hounsfield unit scale. Contrast that with the CT signature of a mechanical valve thrombus. Here, a large mass adheres directly to the mechanical hinges and leaflets. This irregular, low-attenuation mass binds to the moving components, physically restricting the opening angles and crippling the valve's mechanics. By combining precise Hounsfield unit tissue measurements with high-resolution spatial mapping, cardiac CT cleanly distinguishes Pannus from thrombus. In pooled data analysis, CT outperforms transesophageal echo in ensuring the patient is routed to the correct intervention. Bioprosthetic and transcatheter valves have unique failure modes. Instead of acute blockages, these biological tissues degrade slowly over a decade through wear, fibrosis, and calcification. This targeted CT reconstruction highlights hypoattenuated leaflet thickening, or HALT. It presents as a meniscoid, crescent-shaped thickening on the leaflet's aortic side. The thrombotic material is thickest at the base near the stent frame, tapering precisely toward the tip. This thickening is best visualized during the diastolic phase of the cardiac cycle. During diastole, the leaflets co-opt, or close together, minimizing motion artifacts and providing a sharp view of the tissue burden. As the thrombotic burden increases, HALT mechanically restricts the valve from opening fully during systole. This transition into reduced leaflet motion, or RELM, indicates active impairment of the valve's forward flow. To monitor the broader degradation process, researchers utilize advanced radiotracers, like 18F fluoride, in PET scans. These molecular tracers bind to developing microcalcifications, highlighting structural deterioration long before dense calcium deposits become visible on a standard CT. By mapping HALT and reduced leaflet motion, clinicians grade the stage of structural valve deterioration, tracking pathology before it triggers irreversible end-organ hemodynamic failure. Beyond obstruction, the second major complication is a paravalvular leak. These defects occur when blood escapes around the outside of the valve ring, driven by suture loosening in surgical implants or severe periannular calcifications resisting transcatheter frames. Diagnosing these leaks requires caution. Surgeons frequently use pledgets, small synthetic patches designed to prevent sutures from tearing through tissue. On a standard contrast-enhanced scan, these dense patches appear as bright white spots, mimicking the exact visual profile of a small paravalvular leak. These comparative CT scans illustrate how a strict injection protocol resolves the illusion. In the contrast-enhanced scan and the non-contrast phase, surgical pledgets remain symmetrically bright. A true paravalvular leak only illuminates brightly when iodinated contrast is administered. Without this multiphase comparison, perfectly normal surgical hardware can be misdiagnosed as a catastrophic defect, prompting unnecessary interventions. When it comes to diagnosing prosthetic valve endocarditis, echocardiography remains highly effective at identifying the erratic, mobile bacterial vegetations that cling to the valve leaflets. However, the utility of cardiac CT emerges when the infection spreads outward. CT excels at mapping invasive endocarditis that extends beyond the prosthetic ring and begins destroying the fibrous skeleton of the heart. These CT cross-sections document severe, invasive paravalvular complications. Asterisks reveal large mycotic aneurysms ballooning outward. CT distinctly outlines the geometry of the destruction, delineating abscesses alongside contrast-filled mycotic aneurysms, completely unfiltered by the acoustic shadowing that blinds a standard echo. In complex cases, clinicians fuse the structural data of the CTA with the metabolic data of an 18F FDG PET scan. This maps localized spikes in glucose utilization directly onto the deteriorating anatomy, confirming active infection. CT routinely proves infection boundaries far exceed what is visible on ultrasound, providing surgeons the true scale of the required debridement. When a valve fails completely and reoperation is unavoidable, the diagnostic CT scan doubles as a comprehensive surgical roadmap. Surgeons extract secondary safety data directly from the existing scan. They evaluate concomitant coronary artery disease, confirm patency of prior bypass grafts, and measure sternum to ventricle distance to prevent a fatal puncture during the redo sternotomy. By integrating four-dimensional kinematics, exact tissue characterization, and total heart anatomy, cardiac CT elevates the evaluation of prosthetic valves. It transforms a functional, hemodynamic guess into actionable structural certainty.